Today I want to discuss a patient who came to the emergency department with swelling in the neck. A 55-year-old man came to the emergency room complaining of a mass in his right neck which has gotten larger over several weeks. He denies any pain. In the last week, he has been having a low-grade fever for which he has been taking Tylenol. At nights, he has been sweating more than usual and has developed severe itching all over his body. He reports that he has lost weight, but he thought that was due to his poor appetite. He has had no recent travel. His past medical history is significant for diabetes and hypertension, for which he takes metformin and Lopressa, and he smokes one pack cigarette daily. He has no cough, no dysphagia, no shortness of breath, no chest pain, and no vomiting. The physical examination. On physical exam, the vitals are blood pressure 182/80, temperature 101, heart rate 92, respiratory rate 18, the oxygen saturation 98, and the finger stick was 280. There is a large, non-tender mass in his right neck. It is firm and mobile. There are no other nodal enlargement noted. There is no warmth or discoloration of the mass, and the skin is intact. The rest of the physical examination is normal. The blood results came back rapidly and was normal, with the exception of serum glucose of 300 milligrams per dl. So what do we have so far? We have a 55-year-old man with a painless, non-tender cervical mass. He has fever. He has reported weight loss, night sweats, and severe itching. The vitals show an elevated blood pressure. Labs are normal with the exception of hyperglycemia. So what do you think is your differential diagnosis for this patient? Well, this could be a goiter, or a neck abscess, or lymphoma, or this gentleman could be HIV positive, or there could be toxoplasmosis, which could also present as swollen nodes in the neck. Well, we can rule out goiter because his TSH is normal, and we can rule out abscess because it's not tender, it's not hot, nor fluctuant. He should be worked up for both HIV infection and toxoplasmosis. In toxoplasmosis, the head CT shows ring-enhanced lesions. In this patient, he had a head CT which was normal. This patient has lymphoma. His presentation was classic, but could be missed if you're not thinking about it. The clinical presentation of lymphoma. Usually, there is a painless, non-tender cervical mass. This could be also in the axilla or the supraclavicular area. The swelling is due to enlarged lymph nodes known as lymphadenopathy. Fever, night sweats, weight loss, and poor appetite are usually present, and severe pruritus is a significant skin affliction. Skin lesions may be involved, but are confined to the area where the nodes are draining. How is lymphoma diagnosed? The definitive diagnosis is made by lymph node biopsy. Reed-Sternberg cells are demonstrated. Reed-Sternberg cells have large bilobulated nuclei demonstrating an owl's eye. They are pathognomonic for Hodgkin's lymphoma. Basic labs, neck and chest CT and biopsy are the initial steps. However, for staging of the disease, a PET scan is recommended. The Ann Arbor staging classification is used in staging lymphoma. Stage 1 is a single lymph group or single extranodal site that is involved, usually above the diaphragm. Stage 2 is two or more lymph node groups on the same side of the diaphragm. Stage 3 is nodal involvement on both sides of the diaphragm. And stage 4 is disseminated involvement in one or more extra lymphatic organ or tissue. The treatment. Hodgkin's lymphoma is best treated with chemotherapy and radiation therapy. The chemotherapy of choice are bleomycin, doxorubicin, vinblastine, and dacarbazine. Bleomycin has the side effect of long-term pulmonary toxicity, and doxorubicin's side effect is cardiomyopathy. In addition to the clinical presentation of Hodgkin's, the disease has a bimodal feature in that it presents in the 20s and again in the 50s. Patients who are in remission from initial treatment should be followed every 6 months. The summary. Let's summarize what we have seen so far. Most people with Hodgkin's lymphoma will present with painless enlargement of a single node or group of nodes. Fever, weight loss, night sweats, anorexia, and severe pruritus are usually present. Hodgkin lymphoma is characterized by mononuclear Hodgkin cells and multinucleated Reed-Sternberg cells with invariably expression of CD30. Ann Arbor classification is used to stage the disease. It has a bimodal presentation and may be treated with chemo and radiation therapy. An A designation is used for persons without constitutional symptoms, and the B designation is used for persons with constitutional symptoms. Well, thanks for watching, and I hope this short presentation provided a framework on which you can build a deeper understanding of Hodgkin's lymphoma. Please don't forget to like, share, and subscribe. I wish you well. Good night.